Suma, take it away.
Thank you, Rich. And thanks for having me to speak here. Deborah, that was a wonderful presentation. You had me thinking it's maybe not as rare as we thought. Today, I'd like to take the next 40 minutes or so and introduce our department to MOG antibody disease in adults as we understand it today. I'll provide some clinical updates and our experience here at Duke. There I think the big takeaway that you'll hear over and over again over the next few minutes is that there's a lot yet to be determined, which is part of the reason I enjoy neuroimmunology as much as I do, and it keeps me fairly active in keeping up with the literature. But we'll start with talking about some definitions here. So we all kind of throw around this phrase of MOG antibody disease, but what is MOG? It stands for myelin oligodendrocyte glycoprotein, which is one of several proteins that's produced by oligodendrocytes, the myelin-forming cells of the central nervous system. And this protein is present with proteolipid protein, with myelin basic protein, which some of you may have encountered in prior testing, and seems to be a target for antibody production. So like many things in neuroimmunology, there are proposed pathophysiologic mechanisms, and I am so not the person who usually throws up these slides, but this was one that I could understand. This slide here came out in a Lancet review of MOG antibody disease that was just published last month. And if you go from left to right here, there is proposal that there is some sort of trigger, be that molecular mimicry, epitope spreading, which creates the production of MOG-specific B cells. There's a whole lot of immunology that's been looked into here, but the takeaway here is that there are T cells that help differentiate these B cells into plasma cells that then go ahead and make antibodies directed against the MOG protein. You can see that those plasma cells cross the blood-brain barrier right there in the middle of the screen. And those MOG proteins are these little blue balls on the bottom right corner, located on those yellow ovals, which are the oligodendrocytes on the bottom right corner of the screen. And as expected, if there are antibodies directed against these proteins located on these oligodendrocyte cells, there's injury and then resultant inflammation. And this very long list on the right here of B cell activating factor, IL-6, IL-17, GCSF are all cytokines that have been shown to be present in the spinal fluid of patients who have been found to have MOG antibody disease. MOG antibody testing has gotten a little bit of a confusing rep over the last few years, particularly because of some changes in how we perform the assays to test for the presence of MOG antibodies. Since 2015 or so, we've had the availability of cell-based assays, which were made commercially available in November of 2017 when I was a fellow in neuroimmunology. And these assays allow for an accurate detection of MOG. What we found in several multi-center international studies is that there is excellent agreement among positivity rates when there's high positive titers and true negative titers. But when those MOG antibody titers are borderline, there's a little bit more discordance, and it takes a little bit more clinical acumen to determine whether it truly is an antibody that's present with this discrete clinical entity. Previously, we were doing immunoblotting and ELISA techniques that didn't quite discriminate against this 218 amino acid protein that MOG is. And because of that, there may have been some more overlap in positivity. So to try to set this to rest, over the last few years, in 2016, 2018, and 2019, there were large multi-center studies that looked at MOG positive patients and patients with multiple sclerosis. And in all of these studies, the positivity rate in patients with MS who had anti-MOG antibodies was less than 1%. You can see here on the slide, it was 1 in 244, none in 200 in a separate study. And in the most recent study of patients with any form of MS, with 685 patients enrolled, there were only 2 patients with true MOG positivity. All that to say, I think the titer means something at this point. There were also questions raised, and we'll talk a little bit about the clinical presentation in a bit, but questions raised about whether someone may have neuromyelitis optica, which has a sort of similar clinical presentation as MOG antibody disease. And again, more recent data in the last few years from almost 200 patients showed that it was rare for patients to have coexistent positivity of aquaporin 4 antibodies and MOG antibody disease. What that leads us to determine at this point is that MOG antibody disease probably is a discrete clinical entity, and it doesn't tend to have a lot of overlap with some of its mimics, such as multiple sclerosis or neuromyelitis optica. But if you get a positive antibody and it's a low titer and the clinical and lab features aren't consistent, we'll talk about what that means, then it's fair to monitor clinically and not necessarily change treatment patterns based off of one antibody titer result. So I'll step back a few more steps here. That's how we got to the titer and testing and what we're really talking about. But why call it MOG-AD? Well, what we've learned here is that MOG-AD is exactly what it sounds like. It's a MOG antibody-associated disease. It's distinct. We do find that it's separate from our patients with MS or our patients with NMO, but it's phenotypically heterogeneous. And we're still not really sure about the pathogenicity of the antibody, whether it's directly linked to the immunopathology that we see in these patients with this disease, or whether the antibody is a polyreactive phenomena or something that's more of a bystander effect. Just rounding out the pathology on MOG antibody disease, you'll see a similar slide a few minutes from now. We like to compare our known named subsets of demyelinating syndromes and speak a little bit about their pathologic findings, and we'll talk about them in contrast clinically. What I'll point out here is neuromyelitis optica, I didn't mention much about because it's an astrocytopathy. There's different pathologic findings because it's directly involving the astrocytes and the glial cells. In MOG antibody disease and multiple sclerosis, there's demyelination, but the key differentiation there is when we look at the pathology, there's more of a CD4 T cell infiltration in MOG antibody disease and a CD8 T cell infiltration in multiple sclerosis. We're not really sure what that means clinically yet, but we do know that pathologically things are looking a little bit different as we look into MOG disease a little more. We've gathered a lot of demographic and multi-institutional studies that really looks into some of the risks that may be associated with MOG antibody disease. And some of the things we're used to seeing in patients with multiple sclerosis or neuromyelitis optica just haven't been found to be true. In patients who are prepubertal, and I haven't even mentioned the MOG antibody testing that's present in a lot of our pediatric patients, the male to female predominance is about equal. And in postpubertal children and adults, there is some suggestion that perhaps there may be a slight female predominance, but it's nowhere near what we see in neuromyelitis optica and multiple sclerosis. As far as racial groups, there's been no increased likelihood of diagnosis found in patients who have MOG antibody disease. And that's a stark contrast to neuromyelitis optica, where we see it primarily occur in patients who are non-white. We've looked into clinical features such as HLA association, and there hasn't been any significant association found, but there does seem to be an age-dependent phenotype, which is pretty consistent throughout all of our demyelinating syndromes. Younger children have been found to have more brain involvement and gray matter involvement, and the presentation is often more severe in children. However, children seem to have a more complete and faster recovery, and their disease is more likely to be monophasic. So I'll share my story of the patient I met when I first started practicing here as an attending. Her story started way back in 2004 at the age of 19 when she developed right eye blurry vision with clinical symptoms that were consistent with optic neuritis. She had pain with eye movement. She had a positive MRI at that time that showed right-sided optic neuritis, and she was treated with IV steroids and her symptoms got better. Over the next several years, she did have recurrent optic neuritis, sometimes with MRI positivity as well. And due to this, after a few years of diagnosis or initial presentation, she was started on Copaxone. And she continued to have recurrent optic neuritis while taking this. 15 years later, in 2019, she now presented with new left-sided optic neuritis, and she had established care with a new physician in New York. She was still taking Copaxone at that time, and I tried to upload the MRI images, we at least have the report from her institution in New York, and it did show not only left-sided optic neuritis, but these small non-specific signal abnormalities in the pons, possibly demyelinating, not really typical, and she was treated with 5 days of IV steroids again. At that time, in 2019, she was found to have a very elevated MOG titer of 1 to 1,000, and she was started in 2019 on B-cell depleting therapy. She established care with me in May 2020 when she was 23 weeks pregnant. And I wouldn't be me if I didn't mention pregnancy and demyelinating disease. And that was part of the reason she established care, was to ensure that she had a good treatment plan and a plan for resuming her therapy after delivery, particularly because of how many repeated episodes she had had of optic neuritis. She delivered in September 2020, and I resumed her B-cell depletion therapy the month after. And then in May 2021, she told me once more she's pregnant with her second child, as we had timed it and discussed it, and due just a few months from now, with her planned infusion for her B-cell depletion already scheduled for January 2022. So that's sort of the clinical presentation we're learning about MOG antibody disease. And these are the various subtypes or the phenotypes that have been described of this clinical entity. Optic neuritis has been described primarily in the prion form, where there's chronic relapsing inflammatory optic neuritis, which is found to have optic nerve head swelling, and overall the degree of damage is much less than we see in neuromyelitis optica. It's more similar to the optic neuritis that we are familiar with in multiple sclerosis, where patients have sudden onset debilitating symptoms but tend to have a greater degree of recovery. There is a little bit more brainstem involvement, but the other cardinal feature that has been linked to MOG antibody disease is longitudinally extensive transverse myelitis. You'll notice I put the words longitudinally extensive in parentheses. And the reason I shared that is, again, to make a contrast to neuromyelitis optica spectrum disorders. We often think of long segment extensive transverse myelitis as a key feature in neuromyelitis optica diagnoses. However, in MOG antibody disease, that's not a must. There can be short segment features, there can be longitudinally extensive lesions, and again, that speaks to the heterogeneity of this syndrome. What's unique is that there does seem to be a slight predominance of conus medullaris involvement, which is enough reason to think about MOG antibody disease if that's something you see. ADEM, or acute disseminated encephalomyelitis, is primarily a pediatric syndrome, but that is the manner in which MOG antibody disease tends to present in pediatric patients. And then there have been case reports of aseptic meningitis and leptomeningeal enhancement that may have masqueraded as things like diffuse pachymeningeal enhancement or neurosarcoidosis. But again, those are case reports with positive MOG antibody association. So what do we do when we hear these stories? We try to build our case to say, well, is this MOG antibody disease? And are there biomarkers that can help us determine whether it's one clinical entity or another? There are some differences between multiple sclerosis and MOG antibody disease, particularly in the CSF. 50% of patients with MOG antibody disease, which is a bit of a toss-up, have pleocytosis, which can be both lymphocytic or monocytic, but the cell counts seen are much higher than what we are used to in multiple sclerosis. As a contrast to multiple sclerosis, oligoclonal banding and IgG indexes are not positive as much in patients with MOG antibody disease. So it's fairly infrequent for patients with MOG disease to have OCBs or a positive IgG. And as we discussed in that first immunopathology slide, those cytokines are elevated, but not something we typically check in clinical practice. And finally, the utility of MOG antibody testing in the spinal fluid, it's still to be determined. There's a fair amount of data at this point that suggests that there's very good concordance rates between serum testing and CSF testing. And there haven't been many reported cases where there was positivity in the spinal fluid, but seronegativity in the sera. As a result, we don't recommend routinely checking for MOG antibodies in the spinal fluid. And imaging, again, looking for ways to differentiate this from multiple sclerosis and neuromyelitis optica. In the brain, the lesions of MOG antibody disease are poorly demarcated. They are not your typical Dawson's fingers. They are not your typical ovoid, well-circumscribed lesions. And overall, there's a little bit less brain involvement. Some folks group it with neuromyelitis optica in this opticospinal syndrome category. What we know is that it is demyelinating. It tends to affect the spine and optic nerves, as I've mentioned on the right side of this slide. In the optic nerves, just like we saw clinically with the optic nerve head swelling, there's more of an anterior involvement. And on MRIs, there's more perineural edema around the nerve itself. In the spinal cord, the involvement tends to be more central and confined to the gray matter, where you might see that H sign. There's pretty minimal enhancement associated with MOG antibody disease in the spinal cord, which is in stark contrast to what we often see with neuromyelitis optica, which are heavy, inflammatory, destructive lesions. And the disease course. I think we're still learning more about this. It's estimated that about 40% of adults and only 30% of pediatric patients have a second clinical attack within 5 years. And because of that profound monophasic presentation in children, treatment decisions are made a little bit more straightforward. In adults, since it's nearing 50-50, we're still figuring that out. Petra Breo, one of our recent graduates, and I put together a review article on MOG antibody disease that was just published earlier this year in March. And here I've included the table that we put together that compares our demyelinating symptoms that I've been speaking about in today's talk. You see MS on that first column to the left, aquaporin 4, and finally MOG antibody disease. And this may serve as a good reference in the future as you're looking for biomarkers to differentiate one clinical entity from another. Diagnostic criteria. So I've just gone through several points that suggest MOG antibody disease is still fairly poorly understood because of its heterogeneity. And that came out in this proposed diagnostic criteria that was published in 2018. It goes on. There are not just the first 1 and 2 sections, which ask for a monophasic or relapsing optic neuritis, and radiological findings that are compatible with demyelination, but then at least one of the following options, choices A through Y. I don't think that makes for a very good diagnostic criteria. And pretty much what that tells me is we don't know what MOG antibody disease is, and we don't have any clear diagnostic criteria to make this diagnosis with confidence. I think we're still learning. And based on these recommendations, these diagnostic criteria have not been put into practice. I think what this really goes to show is there are several findings that have been shown to be associated with MOG antibody disease, but it's up to the clinician to be discerning about those titers, how they were done, when they were obtained, and whether the entity is more consistent with other demyelinating syndromes or this MOG clinical entity. Well, once you go ahead and diagnose someone with MOG antibody disease, what does that mean for them? I've already mentioned that up to 50% of patients can have relapsing disease. And so there has been some work done looking into MOG antibody titers and whether they can be predictors of relapse. What we know so far are these 4 bullet points. That seropositivity and those titer levels mean very little. Sustained seropositivity, meaning you've treated the patient 1 year out, they still have antibody titers present. It doesn't predict their likelihood of relapse at 5 years. In patients who turn seronegative, they can still relapse. At the time of relapse, patients have been shown to have new seropositivity after they had turned seronegative. Moreover, titers, like my patient with an elevated titer of 1 to 1,000, do not clearly correlate with disability outcomes. But we do know with a very high certainty that at relapse, titers are higher than when patients are in remission. So individually, it may be worth following the titers to try to help get an additional point to suggest whether or not a patient is having an ongoing clinical relapse at that time compared to what their prior titer was. But otherwise, they can be helpful. They haven't been shown to be prognostic. What Petra Breo, who I mentioned earlier, and I did a few years ago, this was 2018, was to put together our single center experience of encountering MOG antibody disease to try to contribute to what we understand about this discrete clinical entity. At that time, we presented our demographics at Duke, and you can see here that many of the things I've mentioned that we understand in 2021 about MOG antibody disease were true at our institution back then. About an equal male to female predominance. The overall age at presentation was in that fourth or fifth decade of life. And the antibody titer ranges that we saw were low from 1 to 20 to as high as 1 to 1,000. The majority of our patients at our center presented with optic neuritis as their initial presentation, and again, about a 50-50 split down here on the disease course of monophasic versus recurrent. In putting this together, we shared our case series on how patients were treated, on what sort of follow-up they received, and whether or not they were started on disease-modifying treatment. And that was the big question. What should we do? If 40% of patients are monophasic and 60% go ahead and relapse, how do we identify those patients when they come into our clinic when they are initially diagnosed with these MOG antibody titers? Of course, there's no randomized control trials yet for both acute treatment or relapse prevention, but there are agreed upon patterns of practice at centers of excellence when it comes to neuroimmunological treatment. Petra and I again looked into this earlier this year, and this was published in April, where we specifically asked a question on available treatment strategies for patients with MOG antibody disease. Acute treatment seems to be standard practice of what we commonly do for patients with demyelinating disease. So if the takeaway is that the patient's presenting with an acute demyelinating syndrome, the answer is still IV methylprednisolone at a gram a day for 3 to 5 days. For MOG antibody disease specifically, there's no sense in waiting for antibody testing, primarily because of the time that turnaround takes for these cell-based assays, and because if it's a demyelinating syndrome, MOG antibody disease has been shown to be fairly responsive to corticosteroid treatment. If severe, meaning the patient is no better from their debility or functional standpoint after a day or two of treatment, it is reasonable to consider plasma exchange or IVIG. But then what to do with steroids? Still to be determined. Some folks determine whether or not someone needs prednisone as an outpatient taper over several months based on the attack severity, the risk of flare-up, which we still don't have any great evidence to guide that decision for, and then the timing and plan for maintenance therapy. What we do know is that in patients who are discharged on a steroid wean, the risk for relapse is highest at the time that the steroids are stopped. And for that reason, it may be worthwhile to consider checking in with a patient clinically at the time of the wean when the prednisone wean drops to a level of about 20 milligrams or less a day, or to think about switching to maintenance therapy or immunomodulatory therapy if their initial presentation was severe enough. As we mentioned, children don't tend to relapse very often, and as a result, the watch and wait recommendation is in place for children who are found to have MOG antibody positivity. But in adults, this is debated. This harkens back to the same question we had for neuromyelitis optica spectrum disorders back in the early 2000s, which is to assign someone, to confine someone to lifelong immunomodulation, which to us in neuroimmunology may not be as big of a deal. Should we wait until a second event? Is it sound to wait until a second episode of debility? And this is still being debated. Generally, our approach is the following. Consider a few things. Consider how a patient did when they initially presented and how their response to the acute treatment went. The severity of the initial attack is worth considering. If someone came in unable to walk due to their transverse myelitis, unable to see, had profound encephalomyelitis that caused them to have a neuro-ICU stay, those are all considerations to take into account to determine whether or not a risk of a second relapse or a second event is worth taking. The risk of short-term disability, similarly linked to that initial attack, is also worth considering. And then finally, age. When it does come to confining patients or treating patients with long-term immunosuppression or immunomodulation, secondary risks such as malignancies and adverse events like infections that can be seen with immunomodulatory therapies do have to be considered. We're still learning about outcomes. Some predictors that have been looked at, and this is true of all of in many demyelinating syndromes, is the time to initiation of acute treatment. The faster you get to these patients, the faster they have a chance to get better. And the more relapses, like the patient I presented earlier, the more chance at disability there is. But overall, the disability does appear to be less than seen in NMO spectrum disorders, but that's a tough comparison to make. It seems to be that MOG antibody disease is somewhere in between when it comes to disability accumulation, in between multiple sclerosis and NMO spectrum disorders. And what that tells me is we don't tend to take a lot of the MS-related disability in stride either, and we perhaps should be a little bit more aggressive about MOG antibody syndromes as well. When it comes to determining patient outcomes on immunomodulation, this is what we know. It's still not big numbers. However, when comparing studies and looking at outcomes at approximately a year out after starting treatment, based on the treatment choices for chronic immunosuppression, such as IVIG, mycophenolate mofetil, azathioprine, and rituximab, you can see which percentage of patients were relapse-free at about that 1-year mark. And the data seems to be strongest from this very small comparison of studies for IVIG. You can see the numbers were much smaller at about 29 patients total treated with IVIG. The next most efficacious appear to be rituximab and mycophenolate mofetil, with the least efficacious being azathioprine. But there are prescribing biases that are clear from looking at this slide that I put together, which is that rituximab is more facile in prescribing often when it comes to neuroimmunology and neuroimmunologic prescribing practices. And it may be that as we start to look prospectively at treatment outcomes, the IVIG and Ritux numbers may equalize. So next steps for us here at Duke, we'll be working on with our division on outcomes data for our Duke MOG antibody disease cohort, specifically to add on from 2018 to now that our MOG cohort has over doubled in size. And as our numbers grow, I think we can learn a little bit more about our own prescribing practices and what choices have gone into play at trying to prevent secondary disability from another relapse. But in the MOG antibody disease world, there's a lot that's yet to be determined. There's still no formal criteria for diagnosis. You saw from that slide earlier how challenging it's been to really pinpoint a discrete clinical presentation that would be diagnostic of this disease. We still don't have natural history data, and that's challenging too, because much of our data is reliant on what we've gathered from single center studies or a few multi-center collaborations with numbers leading into the hundreds, but still not enough to say what's our overall incidence, prevalence, and natural history of this new entity that we seem to be encountering. And then finally, treatment protocols and targets. You can see that there's promise for IVIG and rituximab use. However, there's no clear protocols in place, and we have not yet looked prospectively, and certainly not in randomized controlled studies, on the outcomes of patients who are chosen for long-term chronic immunosuppressive therapy. There is an argument to be made that it's okay because of the heterogeneity of practice and because of our own prescribing practices in neurology, nationwide at least. The hesitations for some folks in starting immunosuppression may be our natural history trial in and of itself to determine whether patients need long-term immunosuppression at all. And that's yet to be seen. That's my update for you all today. I'd be happy to take questions. Thanks again.
Thanks, Suma. So the first question is from Kevin Van Landingham.
Yeah, Suma, great presentation. I realize we've got a limited database to work with, but are there any known associated triggers for MOG antibody disease, recent viral infection or vaccination?
Not clearly yet. So there has been molecular mimicry in recent viral illness has been proposed, but unlike some other conditions we come across, like Guillain-Barré, there's no clear linear correlation that we've seen. And for that purpose, we sort of think of it similar to multiple sclerosis, where there might be multifactorial etiologies that are sort of linking together for the perfect storm.
Thank you. Joel?
Suma, doesn't the poor response to rituximab suggest it's not an antibody-mediated disease?
I think that's exactly our hesitation here, which is part of the reason we call it this wishy-washy term of MOG antibody disease, to say, yes, there's an antibody present, but is that really the pathology? There is some data that suggests that the antibody subtype is this IgG1 subtype that requires T cells for these plasma cell differentiation. And so there's more than just that linear B cell causing damage that we're used to, like in NMO spectrum disorder. But I think you're absolutely right. That Ritux response in clinical practice is what shares with us that we're dealing with something bigger than just a linear antibody mediated disease.
Does that give you any other ideas on other therapies that might be effective then?
So there have been thoughts, but they haven't really been used other than what we're familiar with, as you saw. And so I think with things like Cellcept and azathioprine, again, we end up in a little bit more of a gray zone when it comes to the immunopathogenesis, and nothing specifically has been looked at because of the lack of understanding. I think there's some plausibility in mechanisms that could be explored, but yeah, I think that's exactly the way that we're thinking about it. It's unclear.
Suma, I remember when autoimmune antibodies came out and we were, trying to match the syndrome to the antibody, and then basically we gave up and now you just get a panel. Are we headed that way in demyelinating disease, do you think?
I think we're already there when it comes to these opticospinal syndromes, and Mayo's been genius and put together that CNS demyelinating panel for those of you who may not be familiar with it. But when the story points to spinal cord and or recurrent optic neuritis involvement, it's fair to send that catch-all NMO aquaporin 4 antibody testing as well as the MOG antibody testing, because clinically it can be really hard to differentiate them otherwise.
And Suma, serum and CSF or just CSF?
Just serum, actually. So because of the high concordance rates, serologic testing is all we're recommending at this time.
Interesting. That's way ahead of the autoimmune encephalitis where we're sending
Yeah.
everything.
Suma,
right.
this is
Okay.
Jody.
Hey, Jody.
Thank you for the excellent update. Because you're seeing some involvement of the nerve roots, are folks complaining of peripheral nerve pain?
Yes, sort of similar to the type of nerve root pain that we see in Guillain-Barré, where folks will have this burning, localized dermatomal pain, especially if they're coming in with a myelitis syndrome. And so again, there's some extension past that central gray of the spine to the roots. We do see that.
And does that persist, or is that something that gets better after they move out of the acute?
So if they come in acutely with that, it does get better. Again, we're talking about small numbers, but I can think of one person that I've kept on chronic neuropathic pain agents due to the persistent symptoms, but that's 1 out of about 28 or so.
Thank you.
Yeah.
All right, Suma, everything else is just great job. Thank you so much.
Thanks, everyone.
Yeah, thank you so much. Have a safe day, everybody. Bye-bye.